atrial flutter is a common term which is based on the ECG. It is the term is used. It is the atrial flutter in ECG. You have a presence of a continuously undulating pattern without any isolated baseline. However, in EP terms, MRAT is a more appropriate term. It's a macro-oriented atrial tachycardia, where the important part of the circuit is a slow conduction zone, which forms a critical isthmus, and it is protected by barriers which can be anatomical or functional or both. And ablation of this critical isthmus renders the atrial tachycardia non-inducible, macro-oriented. Coming to the mechanism behind ECG, why you get the undulating waves. This is because during the tachycardia cycle length, some part of the atrium is activated during the entire length of the tachycardia cycle length. Nearly about 85% of the tachycardia cycle length, about some part of the atrium is continuously activated. So this is one flutter wave. This is the cycle length. Cycle length is say about like 250 milliseconds. In this part of the cycle length, this part of the time period, some part of the atrium is activated, and this part of the period, some part of the atrium is activated. So during nearly the entire length of the tachycardia cycle length, some of the atrium is activated. This atrial activation causes electrical activity which is represented on the ECG. That's why we don't get an isolated line in an atrial flutter. On the other hand, in focal atrial tachycardia, most of the atrial activation occurs between the 50% of the tachycardia cycle length. So during this interval, this isoelectric interval, no part of the atrium is activated. That's why you get a straight line. So atrial flutter are usually defined as typical or atypical. This is based on the CTA dependency. All typical flutters are CTA dependent, while all others non-CTA dependents are atypical flutters. So atypical or typical is not based on the ECG finding. It is based on the EP finding. If it's a CTA dependent flutter, it's called a typical flutter. All others are non-CTA dependent flutters. So this is a circuit in a typical counterclockwise flutter, where the circuit is this IVC in back, and the tricuspid valve has been cut away, and this is the mitral valve has been cut away. The circuit goes from below upwards on the roof, below upwards on the septum, and the lateral wall of the array is from the above to below. And you can see that from the IVC to the tricuspid valve is a critical zone. Ablation in this line causes a conduction block across this line, makes a tachycardia non-inducible. So anteriorly it is formed by the tricuspid, and posteriorly it is the crista terminalis. Crista terminalis forms a barrier across which no electricity can pass. So it makes a complete circuit. On the right hand side is another form of a CTA dependent flutter, where the crista does not form a complete barrier, and hence because not a complete barrier, some of the current can go across the crista. So this forms a circuit around IVC. Here again CT is the critical isthmus. This is called as a lower loop re-entry circuit. So this is a anatomy where RA and RV has been cut away. This is a tricuspid valve. This is IVC. Catheter from the IVC is put into atrial appendage, and the circuit, the typical counterclockwise CTA dependent flutter, revolves around this. Behind the tricuspid valve in front of the crista terminalis. Again, creating line from the tricuspid valve to the IVC. CTA makes the circuit non-inducible. So this is a image in the LAO which is seen from below, where the tricuspid valve has been cut away and mitral valve has been cut away. The circuit is revolves around this region between the tricuspid valve anteriorly and crista posteriorly. CTA dependent flutters, usually there are 4. Typical is counterclockwise CTA dependent flutter, which forms about 85% of the CTA dependent flutters. The rest of the clockwise flutter is the same, just in the opposite direction, which forms about around 10%. And others are very rare, lower loop re-entry and intra-isthmus re-entry. In the ECG, the sawtooth pattern that is typically seen in counterclockwise, which is a negative P wave in 2,3 AVF. Just opposite of is the positive wave, which is in the clockwise flutter. Lower loop re-entry and intra-isthmus entry ECG findings are not very typical. All others are called as atypical flutters. Atypical flutters can be RA or a LA flutter. Predominantly they can be post-surgical where there's a scar. Around the scar the circuit is present. Or it can be post-radiofrequency ablation for AF where there will be around the scar, or there may be some part of the AV in slow conduction. Other patients with de novo structural heart disease like in rheumatic heart disease or idiopathic, they have a scar in the atrium. Around the scar, they may have re-entry circuit. So in patients with structural heart disease, typical flutter can have atypical ECG pattern, and atypical flutters can have typical ECG pattern, and focal AT can simulate like atrial flutter. This will come in the following slides. So based on ECG, we cannot make a clear differentiation between typical or atypical flutter in patients with structural heart disease. This is examples of atypical flutters where this is a mitral isthmus flutter where this circuit is revolving around the mitral isthmus. Here is a circuit around the pulmonary valves and the scars. Here in the picture, probably post surgery for any congenital heart disease like ASD or for TOF, there may be scar in the lateral wall of the RA, and around this scar there may be circuit going on, or there can be a septal patch. Around this there can be scar. Around this they can circuit, re-entry circuit can go on. This is ECG findings in a typical CTA dependent counterclockwise flutter. You have the sawtooth wave pattern. When if you closely analyze it, the initial portion of the flutter descent is shallow, then you have a steep descent, which is followed by a steep ascent and a terminal P wave. This is seen in inferior leads 2, 3 and AVF. In lead V1, you can see near this initial one is isoelectric line and then followed by upright P wave. As we move from V1 to V6, this isoelectric line becomes more negative, and V1, the terminal upright P wave becomes like isoelectric. So when you come to V5, V6, it's predominantly like a negative P wave is be present in V5, V6. In lead 1, usually it will be low amplitude and will be isoelectric line. When lead AV is predominantly a positive P wave. This is a typical ECG finding in a typical flutter. So in patient with scarred atrium, when there is extensive atrial disease with scars such as in rheumatic or post-phantom, the amount of normal depolarization of atrial muscle is small. This depolarization of this atrial muscle during flutter will not be able to generate sufficient electric current so that even if this depolarizes, there is no electric current, so that in ECG you can get an isoelectric line. In case of focal atrial tachycardia, in patients because of extensive atrial disease, intra-atrial activation time may be increased such that it may occupy more, the activation of the atrium may occupy more than 80% of the cycle length. Because of this, you don't ECG you can get an undulating line with no isoelectric line. So this is a patient, you can see this the PV is not clear, but there is something like negative PV with a 2:1 AV conduction, but we don't get a classical sawtooth pattern. This was a patient when taken for EP study, it was found to be a CTA dependent flutter. Because of scarring in the right atrium, you don't get a typical sawtooth pattern. This is another patient who's like having a 1:1 atrial tachycardia. You can see is a P wave which is positive in lead 3, initial positive and then a negative. Initially, the patient had a structural heart disease. We thought initially it was a focal atrial tachycardia. However, on taking up to the EP lab, it was found that he had extensive right atrial disease. Because of that, it was a CTA dependent flutter. Because of extensive atrial disease, the conduction in the atrium was very slow, that the atrial flutter rate was low with it conducting 1:1. So how to differentiate based on ECG whether it's from the right atrium or left atrium? Look at V1. If the V1 you have a broad-based positive P wave, it is more commonly is from the left atrium. If it is completely negative, it is from the right atrium. If the initial portion is negative, then it is or isoelectric, which is followed by a positive component, then it's probably right atrium is the origin. If the V1 is biphasic or completely isoelectric, we cannot say. This is a patient It is a post-rheumatic heart disease with post-mitral valve replacement. It came in incessant flutter. This is the P wave you can see is a tall P wave in V1 and it's positive in V1, V2 to V6. This was a flutter coming from the left atrium with a scar in the posterior wall of the LA, and around this scar there was a re-entry circuit. This is a patient with post-ASD surgical closure. Had a flutter, but on ECG it looked like a typical CTA dependent flutter. However, during DP study, this was a duodeca catheter which was placed in the lateral wall of the RA, and you can see that lateral wall of the RA, you can see atrial activity which occupies nearly about 80% of the tachycardia cycle. So this was a scar in the right atrium. Around this scar, there was a flutter circuit was going on. So, how to differentiate between macro reentrant atrial tachycardia versus focal atrial tachycardia? Most important thing is the tachycardia behavior. In case of a focal atrial tachycardia, usually you will have warm up and a cool down phenomenon, and they usually can occur in bursts. On the other hand, in flutter or usually the atrial rate will be like 300 beats per minute. So ventricular rate will be 2:1 AV block will be there. So rate will be around 140 to 150. So if you do a Holter, this is the ventricular rate. Usually in case of flutter, usually have a flat line like this. The rate is around 140 to 150, implying that there's a 2:1 AV conduction. When this goes to 3:1 or 4:1, you can dip to 100 or 75. So this was a patient with a flutter. On the other hand, this was a patient with a focal AT arising from the pulmonary vein focus. Here, this was the baseline sinus rhythm, and suddenly it occurs in bursts. The rate rapidly increases like that. So this is one of the focal AT can present like this, or focal AT will usually may have warm up and cool down phenomenon will be present. ECG findings can be interpreted only in patients with normal heart. Macro reentrant atrial tachycardia usually will have a undulant wave with no isolated line, while in FAT you will have an isolated line. So, conclusion: electrophysiology MRAT is a more appropriate term, where the critical isthmus is the slow conduction zone, and RFA at this site renders the flutters non-inducible. Flutter and typical and atypical flutter is based on a CTA dependency and not on ECG findings. And you should know the ECG finding of a typical flutter, which is a sawtooth wave pattern. Differentiate between RA and LA flutter is based on the morphology in V1. If it is completely positive, it's more in LA origin. If it is completely negative, it's RA in origin. And differentiation between macro reentrant atrial tachycardia and focal atrial tachycardia is predominantly based on the tachycardia behavior rather than ECG findings. The ECG findings may throw out if there is structural heart disease. Thank you, sir.